Next is Dr. Rajendra Prasad, the terminal chopper man, who has evolved so many innovative techniques, and he's going to present one more from his treasury of innovations. On to you, Dr. Rajendra Prasad.
Okay, can you see my screen?
Yeah.
All right. So this is the surgical video of an intermittent white cataract, which is swollen, and you can see very tense and stretched out anterior capsule. And what I'm trying to do here, what we all do is we use the hypodermic needle, sharp tip hypodermic needle to prick the anterior capsule. But what happens, the moment you prick the anterior capsule, the tear starts opening up and extend to the periphery into Argentinian flag site. And this happens even before you start the capsulorhexis or you start the aspiration of the interlenticular fluid. So why it happens? The postulation which has been put forward is the raised interlenticular pressure and the forward thrust of the nucleus on the back of the capsule, which opens up the tear which we have created with the needle in the beginning, and it extends to the periphery into Argentinian flag site. But the more important is not these two factors only. There is one more factor which is more important. That is the configuration of the initial prick. How we are making the prick on the anterior capsule. These are the different types of the configuration we make on the anterior capsule. But when we use the hypodermic needle, when the hypodermic needle or the capsulorhexis forceps to initiate the capsulorhexis, when we prick or capture the anterior capsule, we create a linear cut like what you can see here. The needle creates a linear cut which has a discontinuous edges on both the sides of the entry of the needle. It's open edges, and these open edges very easily open up because of the stretch in the capsule and the pressure which is there underneath. So what we actually, you can see here the opening, how it opens up, and if it goes beyond the equator, then we'll end up into the problem of posterior capsular tear. So henceforth, we came up with an hypothesis, like if we are able to make an opening which is round and circular, like a capsulotomy in a true sense, then we can give resistance to the capsule against these dispersive forces. We can also evacuate the fluid with this capsulotomy which we make on the anterior capsule. We can evacuate the fluid, which will help to reduce the interlenticular pressure and decompress the capsular bag. And once the decompression is complete, then we can initiate the capsulorhexis very easily and complete the rhexis in a normal way without any contamination of rhexis extension. This is how we can do. So we devised a novel tool. This is called as the saving needle capsulotome, which has a round tip and a pointed round tip. And you can see how when it pricks the capsule, it makes a hole. Unlike the linear cut produced by the needle, it makes a hole on the anterior capsule. So if you are able to make a hole in the anterior capsule with a very simple device, you can evacuate the fluid which is there in the capsular bag. And this can be done without staining the capsule also, because you don't stain, or you can do after staining also.
1 minute left.
You make just one opening, or you can make multiple opening on the capsule. If you have a multiple fluid pockets, then you can evacuate the whole pockets in the capsular bag and evacuate the fluid and reduce the pressure within the capsular bag and decompress. So here I'm doing the staining of the anterior capsule. You can see this video. And once the anterior chamber pressurization is complete, this is the capsulotome, which is being inserted into the anterior chamber, and it pricks the anterior capsule. And you can see the moment it pricks, the fluid starts evacuating from the capsular bag. Now, since this prick is a round and circular, it will not open up. And it's so simple, and then you can evacuate the fluid completely with the help of the visco injection and the visco cannula. That is the milking technique. And once there, you can see that now the capsular bag is completely decompressed, and then you can start the capsulorhexis and complete the capsulorhexis. So the pearl is instead of using sharp tip hypodermic needle, use saving needle microcapsulotome, which is round and pointed tip, which makes a round hole on the capsule instead of making a cut on the capsule. Thank you.
Thank you very much, Dr. Rajendra Prasad. You can hear me. I just wondered if Supposing the anterior asociety shows there are a lot of fluid clefts, just making one small central opening like this, are you able to evacuate enough of the fluid from the thing?
No, I have shown only like you can make multiple openings. You can make more than one opening. You can make 4 or 5 openings as desired. But the very important point is like even if you are able to evacuate the one pocket, the decompression happens. See, capsular tear will not extend even if you evacuate the one pocket, but you can evacuate multiple pockets by making a multiple small capsulotomies on the capsule.
What is the size of that central circular opening, sir?
0.6 millimeter.
Very ingenious,
The diameter is 0.6 millimeter.
very ingenious, Rajendra Prasad. But actually, I have the same doubt as Chitra in the sense that, if it was absolutely fluid, this thing that once you puncture it, the whole thing is going to flow out. But very often you have intumescent cataract with swollen cortical matter, sheets of it. And in that case, even if you make multiple punctures, you actually have to go in with a needle and aspirate. Otherwise, it just doesn't flow out.
Yeah.
Will this work well?
Definitely, Dr. Ramurthy, actually, this device shows how you make the capsulotomy, and then you can go ahead the aspiration if it is required. But if the fluid comes out, even if two or three drops of the fluid comes out, the capsule will decompress. And then you don't need to do anything else. Then you know that the capsule is decompressed, and then you can start, like, you know that the pressure has gone down. But if you think that the pressure has not gone down, if it's a fluffy, non-fluid material inside, then you can go inside and aspirate. But never use the needle, because needle makes a cut on the interior capsule. And we have seen even with the small needle aspiration technique, because when you go through the capsule and before you start the aspiration, the capsular tear extend to the periphery. You never know which case is going into Argentinian flag sign. It's the pressure gradient, the optimum pressure gradient, if it is there, so that capsule will extend, not all the capsule. So you never know. So which capsule is going, because in a small needle aspiration, many times we show like we go inside and aspirate and the capsular extension has not happened. Maybe that capsule was not made for the extension. So
Maybe
you
you'd
never
like
know. So pricking the capsule with the needle is the only reason which extends the capsule to the periphery.
Do you actually milk out the fluid because it's a smaller opening? Would that help rather than just
I
allowing the fluid to come out? Do you actually help it to come out?
No, you have seen the video because have you seen the video? Because I showed the milking technique. You
Yes,
have
so
to milk it out.
only because of that.
You milk it out, then the whole fluid will come out.
Thank you. Paucity of time, I'm going to move on. We shall now, thanks a lot, Dr. Rajendra Prasad.